when the government comes into place, what they said in their manifesto, they should just follow, because that is the plan that they have.
Because again, when you bring something that citizens do not have a need, it will not be used. And I have seen projects that have, been implemented with donors and they are dormant, simply because it was either a project too big for the community, they don't know how to use it, and there's a challenge.
You find different sectors are putting money in the same thing. So there is definitely space for health to work with education, to work with agriculture, and to work with social protection. Put their money together towards a certain thing. And we're doing a project on school feeding, and we're thinking about the same thing. Good morning and welcome to Policy Unstuck, a public finance management podcast that decodes public finance management and policy. My name is Wangari Mwekia and I'll be your host today. I have two wonderful guests, Mary Kimanzi and Winnie Mageto. I'll ask them to introduce themselves.
My name is Winnie Mageto. I'm a public finance management specialist at Expertise Global. I work on various elements, for instance, the health sector and the education sector.
Thank you, Winnie. Mary?
Yeah, my name is Mary Kimanzi. I am a certified public accountant. I practice public finance management as a consultant. I also consult with Expertise Global. And in my past life, I have worked as a county executive committee member for finance. What we call a county minister, maybe for other people that don't use that name. I have worked as the county minister for finance in Makueni County for 2 regimes, having joined the county as a chief officer for finance and socioeconomic planning, and was appointed the county minister after serving for 1 year. And I served from 2015 to 2022. When I left the county of Makueni. Before then, I worked as a chief accountant and in various other positions with the Agricultural Finance Corporation. So I have done public finance for over 20 years. Yeah.
Awesome. Fantastic. I am so pleased to have you guys here today. We work together in the office regularly, but I think this is a different context for us. So now is the time where we talk about the things that we've learned over the course of our work. And today we are going to talk about universal healthcare and how we can rethink the financing for universal healthcare, or it's called UHC. You'll hear us, of course, we'll refer to it as UHC. Given the barriers to fiscal space in the country, how can we increase the financing for universal healthcare for the population? So I'd like us to get into some of those issues today, talk about some of the challenges, then hopefully at the end, we'll have some ideas of solutions of how we can rethink PFM when it comes to universal healthcare. So I'll start with some definitions. Not many people know what universal healthcare is. Universal healthcare is essentially providing health services to majority of the population and ensuring that they have access to an essential package of services without going into financial ruin or having a financial catastrophic event because they are dealing with a health issue. So it is primarily delivered, now it's being delivered through primary healthcare being the first level of care where you deal with illnesses, general care from a health perspective, and providing universal healthcare based on those primary services. So when you're thinking about that, you think about promotive, preventive, curative, rehabilitative, I think, and palliative care for, I think, the health professionals in the field. I think they understand what that means. But it's really just basically the whole healthcare service from prevention to rehabilitation. So I wanted to ask you, Winnie, you have worked a lot in healthcare, Cindy. And I want you to take us a few steps back, even with this definition, and say, and ask you, what is the history of universal healthcare? Is it something that just started recently in Kenya? Is it something, where are we with this program? Give us a little bit of background.
Okay, so for the universal healthcare or the universal health coverage, it started long before, just after independence in 1965. That is when we were doing the sessional paper number 10. So it is the famous sessional paper number 10. So it focuses on various aspects of how we are going to govern the country. And health was one of the key important areas because we wanted to provide effective or quality health services for the population. So after that, then there was the introduction of the National Health Insurance Fund. That is in 1966.
1966, NHIF?
Yes, the NHIF. That is when it was established. This is because the Arabs and the Indians had their own cover, the insurance cover.
And even the whites in Kenya.
Yes, those Indians and Arabs, they had their own cover. But the African, like the Kenyan, did not have a cover. So it was through Charles Njonjo. He's the one who initiated the NHIF cover. So he established it in 1966. But then it was just covering people who are salaried employees. So now the minimum earning as at that time for you to contribute 20 shillings was 1,000 shillings. Then now after that, NHIF, there's something that was called District Focus Development, DRF, District Rural Focus Development, which was implemented at the district level. So it was the districts that were pushing, or they were spearheading for quality healthcare. Then after that, we had what is called now, we had a sessional paper again number 7. That is when
I wonder why we always go back. It was 10, now it's 7.
Now it's 7.
That's an interesting thing for understanding another day, but anyway.
Yes, so now they introduced another sessional paper number 7, and where we talk about now universal health care for all. We're talking about everyone, whether you are employed or not employed, you need to have not an insurance per se, but ability to go to hospital without maybe robbing a bank, without looking for funds everywhere. So it was easy for everyone to go to get the funds.
And which year was this?
This was in 2013.
Okay, now we're more recent.
Now we are more recent. Then now we go to 2017 now, where we have now the universal health care, or the universal health coverage under the government of Uhuru, who is now spearheading healthcare through the Big Four agenda. And now we have introduced, we are doing the UHC through 4 counties. We have Kisumu County, we have Machakos County, we have Nyeri, and we have Isiolo. So it was a pilot that was done for 1 year, and it was funded by World Bank.
When you say a pilot, what was involved in that pilot?
In that pilot, they were doing, it is more of you are introducing what you would have wanted other counties to have, the most affordable and quality health service at the preventive level. That is dispensaries, community health centers, and some lower levels, not level 4 hospitals. So that's where they're able to go to hospital and get their
And even just
care.
to put in context, there are 6 levels of hospital.
Yeah,
right?
there's
So
6
there's level
levels.
1, which is a community health services. So the people that go around, the bicycles helping, more promotive health. You know, if you have bilharzia. Remember when you learned about bilharzia in school?
Yes.
Oh, I'm showing my age again. And then level 2 is like a dispensary. There's a small clinic.
Clinics,
Level 3, so they keep going higher. Level 3 is now
these were the former district hospitals,
Yeah.
are now level 3 and level 4.
Yeah, so the health facility, and then level 4 is like
county.
it's a larger one.
It's a larger
level
one.
5 is the highest one at the county level, correct?
County
Mary?
referral
And then now level
hospitals.
6 is now national government, nationally.
Yeah, and referral hospitals like Moi Teaching Referral
Exactly.
Hospital, Kenyatta,
Yeah.
and all that.
And then how it works is like they call them referral because you keep getting
A referral
referred
to
higher
go.
depending on your condition.
Yeah.
Yeah.
So now from then 2017 we had the UHC, and then now under the Big Four agenda, and now we have the UHC under the BETA. That is the bottom-up economic transformation agenda, which is the current. So you see, all through we have had UHC, but just the terms have been changing because you're talking about preventive healthcare, you're talking about promoting quality, affordability of healthcare. So all these governments that have been in place have actually had health as a priority. Yes. So it has always been there. It's just the terms that have been changing.
Okay.
Yes.
And when you think about, I think when I think about universal healthcare, I think about it. I think about it in three ways. Number one, who is covered. So making sure that there's an expansion of services across the population. So not like you said, there was a pilot, right? But then the idea is that everybody. It's called universal healthcare.
Yes.
Health coverage. Always is it
Health
universal?
coverage.
Universal healthcare. Universal health coverage. Universal healthcare coverage. Anyway, it all comes back to the same thing. And so who is covered? Expansion, making sure even from the people who are wealthy, the people who have who are not able to be able to afford and access services. And number two, what is provided? What is the package of services provided? So they always talk about an essential package of services, and there's even a paper around the essential package of services. So what should everybody who is in the UHC, what should everybody be accessing at a basic level? And as I talked about earlier, it is primary healthcare, and primary healthcare has a certain certain services that they provide. And then the last one is reducing of out-of-pocket expenditures. Now, out-of-pocket expenditures doesn't mean that people don't pay for their services. And we can talk about a little bit about that, Winnie. But it means that people don't go through a catastrophic financial event because of an illness. Right? And I read yesterday, actually, that the people who typically go through catastrophic healthcare events are people who are living in households with people who are elderly, 60 or older. That was actually quite interesting to me because I think of a lot of my friends and peers whose families, maybe their parent or grandparent is older and they're in hospital, and maybe they go to ICU, and ICU is an expensive affair. And that can be a catastrophic event for a lot of people. So universal healthcare is there to kind of cushion you from that. You talk a little bit more about catastrophic events and how that is covered through UHC.
So for UHC, there's another thing that actually I forgot to mention just before I talk about the catastrophic affairs. There's something that we called Linda Mama. You remember that there was something that was introduced actually in 2013.
What does that mean
Linda Mama
in
is maternal health care.
Yeah.
Like it was free. It was actually dubbed Linda Mama. And we had something called Linda Jamii. Linda Jamii, where we had, you talked about, when you're talking about UHC, it's not about removing all the charges. We have some charges. So like there is some charges that these women pay at the inception of going to hospital. They pay some registration fee, they're registered there, and they get a package for the 9 months that they'll be going to hospital when they are pregnant or they are expectant. Now for the family, they were paying a small fee. It's called Linda Jamii. That was when they introduced some fee. So people of lower income were not able to pay, but this small pay that other people are paying is able to cater for everyone. That is why everyone is covered under that maternal health care, and also someone else is covered who is not able to pay under the Linda Jamii.
And that's what's called, in a technical term, risk pooling.
Yeah,
right?
risk pooling. So you're pooling, everyone is in the pool, but a few of us were able to pay, are able to pay so that everyone else is able to get medical care. So Mary spoke about something Mary talked about being a CEC finance in Makueni County, and they talked about that there's a health package that Makueni had offered. Is it similar to what maybe the national government is offering?
Okay, the Makueni case, of course, was born out of need, seeing that citizens were struggling to pay for healthcare. And actually what we observed is that a lot of people would refuse to go to hospital or would not go to hospital because they cannot afford. So the Makueni case is similar, but in our case, we had to make a budget provision to take care of the patients, and this replaced what they used to pay as fees. The county, by the time we were introducing the the UHC. And I think we were the pioneers. We were actually the pioneers of universal healthcare in the country.
It was called, it had a name, was it Makweni Care?
Makweni Care, yeah. So, we began by looking at what were we collecting from, providing the services. And we saw that we were collecting around 100 million per year for offering the services to the people.
Is this for across all hospitals? Or
whatever was being pulled to the kitty? Before the county governments came in, the hospitals had what we used to call the Facility Improvement Fund. So they used to collect under that fund. So when we looked at what came from all the hospitals in the county, it was just 100 million. But we'll be talking about the cost of healthcare. It's really expensive, far beyond the 100 million. So the question was, guys are not going to hospital. We are not even getting so much from it. Suppose we made a provision for this budget, and then we collected it in a different way, like having the citizens. Then our county had 200,000 households or thereabouts. So like if every household out of the 200,000 paid 500, would still collect this 100 million. So can we devise a way of ensuring that people get to pay something towards a pool, and then we provide this service to the people?
And when the house pays, do they get a code, do they get a card?
Yes, they get a card. They get a card, and the card is used to access the healthcare. And I think as we speak, they have automated so that, every year they renew and they get to access the service. It's still being provided. Of course, with time, it became a little expensive because now you see people who never went to hospital began accessing the health. And this is a beauty when the government can introduce some of these things, because it ensures that citizens that are unable, that are vulnerable, that are,
who may not have been accessing before,
are able now to access healthcare. They're able to go to the hospital. Can you imagine a patient being in ICU at only 500 per annum? And this is what
and that's
she mentioned.
500 for the family, not just that individual.
For the whole household, for the whole household. Actually, it was far much cheaper than the NHIF, which was it 3,000? No, 6,000 per annum. Yeah, so that's how we did it. Maybe it was slightly different because the funding was coming from the households. But of course, healthcare being expensive as it is, the government also made a very big provision towards healthcare, far beyond the 100,000. Because if I may remember, like the drugs alone, medicine for hospitals would consume like 300 million, 400 million. Yeah, and especially when more people began going to hospital and all that. So there are similarities in the way we implemented, but maybe a slight difference in the way we mobilized the funds. And of course, I think as we speak, the amount has been raised to about 1,000 because the 500 was not sustainable. So now we had to think of raising it a bit.
And thinking about that, I think to segue to the next question, because we really want to target in on health financing. Talk a little bit more about affordability. From your position as the Minister of Finance in Makweni, former Minister of Finance, what were the financial difficulties when it comes to health financing in Makweni? Was it difficult to, before the Makweni Care, was it difficult to raise the finances? After Makweni Care, you provided the 100 million, but you said it became financially difficult. Can you talk a little bit more about that?
Wangari, money for financing healthcare is never enough. Is never enough. I actually think even if we gave them the whole of the budget, they would still, find
a way to,
the budget is not met.
And actually, even as you're going, sorry, just a quick one, as you're asking, how do you know someone is a resident of Makweni or not and can access that service?
The ID was the one that was used most. It has to show that you're born and you reside in Makweni. But I think they also had a way, I don't know whether it's through an introduction letter, of ensuring that people that actually reside in Makweni and come from elsewhere, and they are known. You see, when you serve people at the local level, there's a beauty with it. You just know the people. Like you don't need to verify that Mary
already
lives
know
around.
you
You already
name,
know.
mwana
So
anze.
there was a way of just ensuring that people know that you come from Makueni, you live there. And, you know, if you come from elsewhere, you have been a resident in the county for so much time. And you cannot be accessing the healthcare unless you are a resident because it's also local. So really, that was not so difficult to establish who came from where. Yeah, so that's how we were able to identify the citizens and we were able to give them. So now I was trying to explain this issue of the budget for healthcare. Healthcare is it's expensive. Most counties, if you look at the budget, will allocate 30% of their budget or more to healthcare. And it will not be enough, Wangari. I like the issue of the Facility Improvement Fund. And though after the county governments came, it kind of went down because the thinking was money can be collected centrally and
used for general budget purpose.
Yes,
yeah.
and but you realize the way hospitals operate, they also need money quickly. Sometimes they need money for emergencies. You cannot tell them you are requesting for money so that they can fund an emergency. So there is need to promote that facility improvement fund. But allocating budget for health was not easy. We used to argue with the team over the funds. Sometimes they would make us feel like
You're killing the people of
yes,
Makueni.
yes. In fact, they used to tell us we'll kill the people if we don't provide money. And of course, you know what they meant, however threatening the statement may
it can
sound.
be tough.
But it's never enough. So when you look at even the number of staff that health has, actually in Makueni the payroll was half. 50% went to financing healthcare, if I may say. We got to a point we were asking ourselves, and maybe this is a debate we can have, is health a recurrent budget or a development budget?
Because you explain for our listeners what a recurrent and development
Oh, okay. Yeah, recurrent budget is a budget that is used for
things like salaries,
operations and maintenance, and salaries, repeated expenditures that are consumed, and that's it. You consume and you cannot pick it back. I don't know how to explain that. But it's budget that is just banned. It's used to manage the other activities, if I may say. Budget for salaries and operations and management. Development budget is like investment.
Infrastructure.
Like you invest in infrastructure, you invest in the roads, you invest in
buildings,
even in the hospitals. But now we ask ourselves, though this is a soft thing, when you have a healthy nation, you have a developed nation. When you prevent diseases, you keep healthy people. And healthy people mean a developed nation. So why don't we look at health budget or money going to finance health matters as money going to development matters? Well, that's a debate that can be raised and people can discuss. And maybe by so doing, then we stop looking at, the money is just recurrent because of the benefits that come with it. But that's a debate that can be there. So it was never enough. I would argue that it may not be enough anytime soon. But when you look at how you can use universal health care, probably it is a way of helping this budget. Because if now you pull the small resources here and there, or if there was another way of citizens making a contribution to that kitty called, for funding universal health care, maybe that way we can be able to mobilize funds enough to ensure that the budget is not so constrained. Because budget allocations towards healthcare are actually huge and may not be enough in the short run. We need to mobilize enough funds to be able to fund healthcare. So I don't know whether I have addressed the question very well, but that's how I look at it.
Interesting. You're talking about the sufficiency of financing. One thing that came to mind was the Abuja Declaration. And the Abuja Declaration states that every government should aim to allocate at least 15% of the budget to healthcare. You, from your experience, how feasible was that for you guys in Makueni, and how feasible is that at Target? Because I think there are very few countries, save for places like maybe Rwanda, which is one of the pioneers for universal healthcare, that are actually able to achieve 15%, especially in a context where we're in high debt problems, revenues are not covering our debt obligations, we're always in a fiscally constrained environment. From your experience in Makueni, was this realistic? Is this something that people were growing to? And then maybe Winnie, you can come in and talk about in Kenya, generally, how much, I think it's about 6% now what we're putting in healthcare.
For national government, is around 2%.
2%. The counties are doing better than national government.
Although healthcare is a devolved function. So
it is devolved, but did the funds follow the functions?
No, not fully.
It's a question.
But, yeah.
Because actually it's interesting because health was almost fully devolved,
I'm
except
actually
for
wondering.
the referrals and health policy. But when you look at the budgets, you're surprised to see how much money is actually at the national government and what are they doing?
That's how called 6% is still a lot of money.
Yeah. I mean, I did look at the budget yesterday. I was looking at the budget, and there's a significant. I think it was the 2021-22 budget. I think they have put about 116 billion, which is quite a significant amount of money. I mean, if you think about the equitable share itself, equitable share is about 300 and something billion. So that's like a third of equitable share. So how do you justify that as you're responding about the 15%?
You see, the counties are actually doing better than the national government because most counties are allocating more than 20-30%. And you know, Wangari, working for county governments and being with the citizens pushes you to address their needs. There's no way a county can fail to address the healthcare need in the county. So we were able to allocate that. Of course, given a choice, we would give less, but seeing the need and what needed to be supported in healthcare, we had to provide, budget to the tunes of 30. In fact, at one point, I think it was 35% of the total budget. And of course,
35% health or 35%?
Yes, of the total budget. So I mean, counties have been able to meet that budget. But when you look at the budget nationally, then we fall short. And the question is, really, how can we, be able to manage this? And you have talked about the huge debt that the country has to deal with. And, unless we come out of some of these things, we may not be able to get to the level that we want. But it's something achievable. We can advance every day because a healthy nation is a developing nation. When people have good health, they're able to invest, they're able to work, they're able to be productive. So how can we not get concerned and think of how we ensure that we fund healthcare? So there is need really for the national government, for the county governments together to think about this. Sometimes I ask myself, suppose the working class, willingly just invested in healthcare for the citizens that do not work. Maybe under the social insurance fund, this may be achieved. But we need to get to a point where we look at how we can universally fund healthcare for the people that are vulnerable. Maybe Winnie can, give us our thinking about this. But, from where I sit, I'm just thinking of how this works out and how then, I will pay for the insurance, not for myself, not for my family, but for another vulnerable person that may not be having someone working to be able to help them. That way, we can also be able to mobilize more funds towards this kind of an insurance that will fund everybody. But I'm sure she has
what do you think, Winnie?
more experience in this.
Okay. So when we talk about a universal health coverage and we want to pull resources to finance this health, so let us just look back when we are talking about national health insurance, the NHIF. Like right now, if you go to some hospitals that you with an NHIF card, the likelihood of you being treated is very low. What does that mean?
Maybe they are unable to pay or to service.
Because the NHIF is also late in its disbursement.
Not remitting actually not remitting, like they have very many years.
They have not paid.
They have not paid the hospitals. So the hospitals will reject such kind of insurance scheme. So as much as we want to pool resources at national level and county level, are we implementing? You see, the paperwork is very good. We have very good policies for implementing universal health coverage and all that. But now the problem is implementing. When these hospitals, why are they able, like the private insurance, why are these hospitals taking insurance cards from private hospitals and they accept to treat the patients? But when it comes to the government, they say, if it's NHIF, we are not going to treat you. You need to pay cash, or if you have another insurance, we are going to treat you. So that means there is a challenge somewhere. As much as people, like the employers are employers actually remitting the NHIF. But now the problem is at the implementer, the national government. Is the government remitting money to
And actually,
to these hospitals?
you just take a quick step back, even when you think about NHIF, NHIF is funded by contributions from employees. And that's the primary source, correct?
That's the primary source, yeah. So the problem is not actually how we are going to pool resources. People will be willing, like for example, you talked about Makueni. I think right now people are able to pull more because of the services they got.
Yes.
But if I'm paying and I'm not getting value for my money,
You will not
I'm not
invest.
likely to pay. So the problem may not be contributing. The problem is, where are we losing it at the national or the county level? Where are we losing it in terms of remitting the money? Yes, citizens have come for the services. They have been contributing as NHIF members, but now they are not able to get the value for the money they contributed. Yeah, so I think that the challenge, there are other challenges also associated with healthcare financing. For instance, we talk about the allocations. We talked about national government allocations. There could be, you see, the World Health Organization requires that the national government contributes at least 5% of its GDP to health expenditure. But in Kenya, we have at least 2% of our GDP towards the health. That is at the national level. So looking at even the Abuja declaration, we are not, it's not, the national government does not even near the 15%. We are maybe there 3 to 4%. So we still have a huge challenge. On paper, we have very good policies, but now the problem is implementing and actualizing. Another challenge could be the limited fiscal space. We see we have a lot of debt. Looking at the latest CBK bulletin on debt, we have, our debt is around 11.2 trillion. So now most of the money that we are going to collect from the KRA, most of it is going to repay debt. So what is going to happen to the money that we are going to allocate to other sectors? For instance, social protection, health and education, very little. So we need a lot of rationalization of the budget, prioritizing, and also implementing of the projects, so that we're able to see, as much as we are prioritizing health and we want to achieve the universal health coverage, we have a huge challenge on how we are going to implement this program.
And it's true. When you think about, I think now it's a good segue into health financing, because if we think about health financing, and we think about the resources that are going into the health sector now, our reliance on external financing, the question that comes to my mind is, we've already seen what happens when suddenly external financing is taken away. It should, in my mind, be a priority in all the local government health ministries and also national government health ministries. As a policy, how do we increase our fiscal space generally for all sectors, but also especially for the health sector, that is a very critical and a very visible sector, right? That we have enough financing. Like, that should be a priority in the mind of the leadership, saying, we cannot continue to be reliant on external financing. We need to find a way to expand the fiscal space. We have seen from the KDHS, the Kenya Demographic Health Survey, we saw a lot of, we have seen that the indicators are improving. Healthcare for women, sexual reproductive health, children, nutrition, and all of that, they're generally improving. But of course, we're still a long way from where we should be. So really, if we are talking today, you are taken to see President Ruto and the CS Health, and they were like, Mary and Winnie and Magari, we need more money. Healthcare, especially health. What is the place we go to, where are the things that we look at. And maybe if I start, if I say, number one, we need to expand the fiscal space. Of course, we think about our debt. And now that's when we start becoming broad, because, fiscal space is more than just looking at health. So how do we expand the fiscal space? Number one, we need to manage our debt. That is a whole podcast for another day. We will talk about that. We talk about the tax environment. It's a high tax environment, but are we receiving the services, like you said? What is that resources used for? And even going back to debt, what are we borrowing for? You talked about recurrent expenditures. The money that we borrow, even if you are individual and you go to the bank and say, I want to borrow money to buy food from every day, they'll be like, so how are we getting our money back? I'm giving you money to invest in development expenditures, which you explained what they are, because that, if you invest in capital, it will generate more capital. But if I give you money to buy ugali, maize flour, you may not be able to generate an income from that. So it's a similar when you look at an aggregate perspective. If you look at government, you should not use your money, debt money, for recurrent expenditures. You should be using for investment. But we don't have an eye to what we are spending on when we borrow all that money. So a question for us is like, how are we recouping that money? So around that, and then you think about now issues of corruption. And sometimes we talk about corruption all the time. Paka, we don't even care. Nobody even blinks an eye when you think about corruption. But the amounts that are siphoned away, and these days we're talking about budgeted corruption. You saw the controller of budget talking the other day about corruption that is actually budgeted in our every year. The amounts that are actually siphoned some of these things could finance the health sector and a lot of these things going forward. So, like, if you think about fiscal space, yes, there is space for improvement. What do you think are some other ways we can think about expanding fiscal space and the money that we have, maybe savings, efficiencies, and things like that? Go ahead.
Wangari, when you listen to Kenyans, they are already overtaxed. So, like, if you think of where else to get money, you may not want to go to taxing people more. Maybe the question we need to be asking ourselves is around utilization. How are we using the money we are generating? I mean, how did we get into debt? Were our priorities right? Suppose in the course of borrowing and investing, suppose we invested in health, would we be in a better place so that, we are saying we are able to avail better health care because we borrowed and invested? Maybe we just need to hold it. This money in debt, where is it? The accountant in me. Where is this money?
You want to hoard the money.
Yes. What has it been able to do? Has some of it gone to health, and how much? And what has gone to health? Is it helping the citizens? Because again, you can go to hospitals and find abandoned machines. Either because they are not repairable, or maybe they procured something that, maybe not procured, got something that probably was not useful at the moment. I know there's a time when counties were also getting machinery for use from government. Sometimes they would even probably get something that they didn't need for the moment. I don't know whether, they were given out of an identified need. Because, in this era, you cannot just give people what you imagine they want. You have to agree on what they need. So the question, Wangari, for me, is not how much more revenue, especially from taxes, because we cannot tax more. Maybe it is, how do we utilize the money? Are we efficient in the way we are managing? Is NHIF, as it goes out, efficient in the way it has been managing the funds it gets? Because if you get the money and you use it because they use the same money for their own expenditure, how much remains for the hospitals? I remember a time I went to hospital, before the situation is what she's explaining. I went to Nairobi Hospital and I had 2 cards. Then my employer was using NHIF, and my spouse had another insurance. I think it was either UAP or or one of these insurances. And when I went there, I told the guy I have two cards, NHIF and this other one. He said, give me NHIF. Meaning there's a time it worked well. So when did it stop working well? When did they stop paying? And what made them stop paying? Another audit. Is there proper utilization of these resources? Are we efficient? So for me, Wangari, before we even start thinking of where do we get more money from, the question is, how have we used the money that we have been able to collect before? Are the priorities right? Are we also deliberate in funding health? Because you have to be deliberate. You have to say there is a need, there is a gap, it needs to be filled, and we have to fill it this way. So when we look at that, then we can be able to discuss, whether we can actually be able to improve on funding health. But I agree with you and all Kenyans. Debt is worrying. We have to think of how to pay it off, but we cannot pay when citizens are not okay. So we have to be deliberate also in making sure that we allocate money towards health.
And actually, one thing you said reminded me of, I was doing a project in one of the northern counties, and we found that there was a big challenge that came in devolution, because when the health functions were devolved, we found that the different counties stopped using KEMSA for central purchasing. When you use KEMSA, you have economies of scale. You get good prices because you're ordering in bulk. But we found that the counties started to purchase on their own, which means they're ordering smaller quantities for higher price for places that are not maybe well regulated. Some countries that are producing medical equipment that may not be up to national standards, but because it's not going through KEMSA, which is a Kenya Medical Supplies Agency, there was not that regulatory function. So what I found is that when I went to the hospital, there was a room that had many incubators. Incubators that they had imported from a country that is not known for doing good incubators. And what happened is there was a newborn that was a premature baby that was put in the incubator, and because of the lighting wasn't of standard, the baby got burnt. The preemie got burnt. And so they took all those machines and they put them away. Nobody is going to agree to use them, right? So it was a waste of millions of shillings, right? So that's central purchasing. And I think this is one of the tenets of UHC, if I'm correct, is strategic purchasing. Strategic purchasing is around making sure that you purchase healthcare products, HPTs, that and other services, health services, that are in line with the need of the population and prioritized, strategic purchasing, which is prioritized. I don't know what you think about that.
About the purchasing. So about the purchasing, what needs to be done? What I know about immunization, it all goes through KEMSA. That is the beauty about immunization.
Even though KEMSA has had its problems.
Yes, they're still very good with the procurement. So about immunization, I know even remote counties, not remote counties, but those counties that are in the rural areas like Kilifi and Kwale, all those counties down there, they're able to get the immunization from Mombasa because the KEMSA in Nairobi is able to transfer to Mombasa, and from Mombasa the community health workers or those people in charge of hospitals are able to come and take the vaccines from Mombasa, then they're able to distribute. This is because there's direct line from KEMSA. So it's easier if they purchase through KEMSA. So there's another point that I wanted to add on maybe why the other challenge of financing these healthcare. Another challenge could be priorities are mixed. Like we do not have, like, you see a new person comes in office and they want to do another project that the citizens are not even in need of. So for instance, at the county level, you would build a hospital that maybe is not needed. There are 5 health facilities, but you build another 6th one just because of your own, maybe your own legacy, initiative or your own legacy for future. So maybe our priorities need to be based on the annual development plans, the county integrated development plans, that 5-year term plan. And also when the government comes into place, what they said in their manifesto, they should just follow, because that is the plan that they have. For instance, right now we have better, the bottom-up economic approach. They should just come and give us what they had already told us in the plan, instead of diversing. So we need to have our priorities, because if we are implementing based on the priorities, the needs of the citizens are also part of your priorities.
But let me ask you, let me probe further on that, Winnie. Because as you know, we're doing a project that's trying to link financial and non-financial flows. One of the challenges that is emerging is that we're seeing sectors, and let's say, for example, now we say the health sector in this example, they deliver services, they understand what the impact of their services are, they understand what the outputs are and the outcomes, and they say, with this, these are our plans for the year. Then they go back to the National Treasury and say, for next year, we need these resources for this plan that we have. The challenge is the national, we're dealing in a limited fiscal space. And not just the health sector, all the sectors are coming with their big plans of what they want to do. But there are scarce resources. There's not enough money to finance everybody's budget. So what the National Treasury has to do is they have to reprioritize the budget, or they have to cut financing. They say some health sector is looking for 200 billion. They say we can only give you 100 billion. And so it's up to the health sector to then now cut the budget. So now prioritization of the budget sometimes doesn't happen, because the budget cycle is fixed, and sometimes there are short timelines, right? So the health sector sometimes gets cut, and then they are unable to link the outcomes that they're seeing with the financing that they're getting. So sometimes you look, and sometimes I've looked at plans, and I look at the plan and I say, why does this plan not match what the money is saying? Why are these guys not planning well? But actually the problem is much deeper, because number one, there's scarce resources, but also number two, the people working in Treasury are not embedded in health, for example. So sometimes they're not talking to each other, and in the reprioritization, some things get lost in translation. So there's a real problem in the management and planning when it comes to budgeting, because then now you find there's a lot of because of scarce resources, some things are not funded.
Wangari, can I try responding to this? Because I have been in that situation.
Yes, in fact, you are the one who are cutting people's budgets.
You're the one saying these people in Treasury. I was these people in Treasury. You see, actually every department, every ministry, even at the national level, as a strategy, they have a plan. They even have a budget they propose to the Treasury. A lot of times, the budget is huge, Wangari, so that it's actually beyond the money that you're likely to have. And that's where the problem begins, like you're saying. So you find that the Department of Health, the Ministry of Health, brings a budget indicating what they want to spend and on what. And imagine that's how, at the county level, and I'm speaking across the counties, they were able to push their budgets up. And the treasuries were able to listen because they are with them. They are with the people. And when they say, the people will die when you don't give the money, you imagine it is your people. So, I mean, it is your people. You are working at the local level and you can see the citizens need it. That's how the money was pushed. But Wangari, it's never enough. It can never be enough. It can never be enough. And that's how you end up slashing down the budgets. Now, the problem comes. When you tell them, you are asking for, say, 500 million. Please slash down to 400. The departments of finance or the ministries don't slash for them. It is them now who sit and decide this is not a priority, or maybe it's a lesser priority. The department or the ministry, they will decide and then they will chop something or, remove one of the items that they wanted to do, and then they're able to do whatever remains with the kind of money that they have. But definitely, they will remove something important because they felt that if we did it this year, it would have made a difference in the lives of people. So the thing is, you cannot do without chopping budgets, I must say.
But sometimes I see what happens. Sometimes what I've heard in counties I've worked in, they say sometimes the ministry is involved, but sometimes they're not. And it's maybe the parliament is the one who cuts, or the treasury that one who cuts. Maybe some counties were unique, but then you find someone has bought beds and mattresses, but they've cut the budget for sheets. So then now when you come, you find the bed and a mattress. How is it going to be used without a sheet? So I think some of these things, and I understand. And I think also one other problem, because I know we need to move, is also the behaviors. Because if I'm someone who's creating a budget for the Ministry of Health, and I know every time I give a budget, they cut it. My incentive, my behavior will be to overinflate the budget. So by the time you cut, I'll reach where I want. And so that is where budgeting starts to break down. I think I want to move on to the next two things. I just want to wrap up, and I want to ask you about two separate things. Mary, I want you to talk about absorption, because on the flip side, sometimes you get enough money, but when you look at absorption, which means the rate at which you spend that money. If I give you 100 shillings for health, I want you to spend that 100 shillings. But sometimes what you find is I give you that 100 shillings, you've only spent 60 shillings. And so I come and ask you, see, I gave you enough money, but you didn't spend. What is the problem? So I want you to speak about that. And I'll come back to you, Winnie. I want you to talk about off-budget financing with development partners. What is the challenge when it comes, when development partners give money and it is not seen, Treasury has no sight or knowledge that that money has actually gone to spend for a certain item, which is called off-budget financing. And as you're thinking about that, I think I was also thinking about one more solution, which is around cross-ministerial synergies. So people in the health sector, they talk about social determinants of health. They talk about education, they talk about livelihoods and things like that. I know AMREF, we did some work with AMREF, and those are some of the social determinants that we're thinking about. That actually, you find different sectors are putting money in the same thing. So there is definitely space for health to work with education, to work with agriculture, and to work with social protection, put their money together towards a certain thing. And we're doing a project on school feeding, and we're thinking about the same things. You know, you think about the transport, you think about the food, you think about the health sector, you think about social protection. All that money, they are putting their budgets for the same thing, but in different departments. So if there was a way Treasury could rationalize and say, and have a vision to say, all these are funding the same things, why don't we just pull them together? I know administratively it can be challenging, but that's one of the things I was thinking about that can be fleshed out. But I want you to address the absorption, and then you address the off budget before we close.
Wangari, I think what you're saying is important, and I think it is to really carefully implement what we call program budgeting, so that we look at that program, what is it promoting? So that if it's promoting health, then we do it in a way that we pull together those little things from all over, and they are managed from one place. And that way, you're able to use lesser budget to achieve, so that people do not duplicate effort. That way we
work in silos. That's
why
we are not able to cross.
Yes. We need to budget together. We need to think program. We need to pull certain things together so that we are able to implement a program, minimize costs, use less money, and be able to achieve the goals and the targets that we have. Now, as I move to absorption, I want to make a comment with regard to sharing budgets. You see, the budget process, Wangari, begins in July. We do what we call a review outlook paper, national, county level. We get to what we call, of course, it begins with the budget circular, then we do the budget review outlook paper. We get to do what we call the county fiscal strategy paper for the counties, and at the national level, there's a strategy paper. Now, this paper allocates budgets to departments and ministries. It is from that allocation that one is supposed to now begin projecting their estimates for, and a budget is formulated from, that paper. So it's possible for people to keep within the ceilings provided through these papers. But sometimes the ceilings go beyond because of the need to meet or to be able to implement bigger things, and that is how now chopping begins. So I wanted to tell you that it's important that people keep within the papers that are released either at the national or the local level, maybe in our case, the local level. And those papers guide very well towards budgeting so that people do not end up chopping budgets and buying the wrong things.
But on the flip side, now absorption. Tell us about absorption.
Yes, and it is related. Sometimes you give these people the money and the money is not used. Some of the challenges come with the procurement. By the way, procurement can be difficult for government. Sometimes you start procuring something, on the way you are stopped because of interest or processes that didn't go well. Sometimes you even go up to the end and the processes are stopped by people who want to question and raise issues. So that happens.
Which is not bad. Checks and balances is good.
It's a good thing.
Sometimes
They delay
have
processes.
interests, yeah.
But then you'd rather get it right. Although sometimes that can also be a problem. Like you see, in health, you want to procure and, procure well, but procure quickly because there's a need that needs to be met. Another thing that affects procurement, of course, is the implementation process. Like if it's a project that needs to be implemented and you don't get the right people to implement it, there can be a delay, or it's technical. Some projects also take long. And again, the problem of also projecting, like, is this project are we able to complete this project within the year? Because if you're not able to complete within the year, then you should face it. But some people want to put all the money the first year. Then at the end of the year, you're not able to absorb. So that is a problem that happens across counties of not being able to absorb. And it is cured by more accurate budgeting, if I may say, by ensuring that procurements are done within time. And there is normally a procurement plan, like how do we procure the whole year? But sometimes people do not follow the plan. Then, of course, there is the challenge also that comes with the money is not being released on time. Sometimes money comes late towards the end of the year, and sometimes even after the end of the year. But then, though the National Treasury will allow people time, like 2 or 3 weeks to pay off the expenditure, sometimes it's not easy because the system is also busy. So people end up not being able to absorb the whole budget. And of course, you cannot rule out the issue of just poor implementation. People not getting it right, officers not getting it right, and not being able to just procure and to implement the project on time. So all those are things that bring out the challenge of absorption. And to cure it is to budget right, get the right people to implement, ensure implementation of the annual procurement plan within time, get the right contractors to do the job, and that means you have a list of the right contractors, and it means you have seen the project that they have been able to do and that they are able to complete the projects on time. So those are some of the things that, people need to do to ensure absorption.
Winnie, talk to us about off-budget.
Okay, so off-budget financing may be done through 2 ways. Normally, it's done through 2 ways. So through the ministry, it can be done through the National Treasury or the Ministry of Health. So, but this funding doesn't come from the national government. It comes from the donors. So when they bring this money, they want to achieve some milestones. And you see, you have to achieve some things before this money comes, like milestone A has to be done before the money comes. So you start a project, and before you, because you have to achieve a certain milestone for the money to come, because of the challenges of maybe human resources at the county level or the national level, we are not able to implement this project. So the money doesn't come. We initiate or we launch a big project, but we actually do not finish that project. So another thing is that this money may be tied to conditionalities, other conditionalities that are not even, maybe they could be funding an initiative maybe on water, and our problem is not water. So they are tied to some conditions which are not our problems. So these problems, they need to come, if the donors want to really help the people, they need to identify the problems that these people face.
And link up with the plans that are already in place.
And link up with the plans that are already in place. And also give a timeline. Don't be there for too long so that these people over-rely on that project. give a timeline, and link the project with the people. So that becomes very easy. We're able to finalize the project. We're able to see the effect and even the impact.
And even like for off-budget financing, as we wrap up, off-budget financing can be really detrimental, because you find a government is budgeting to finance a particular thing, but they don't know that the donor is also financing that thing. So you find there's double financing. Whereas if the government had known, they would have redirected those finances to another sector. So I think off-budget financing it seems good sometimes because it is fast and people can use it quickly, but at the end of the day, it ends up being detrimental. And I think also to your point, Mary, is that one of the solutions also for absorption is to allow the heads of office to delegate the AIE, the Authority to Incur Expenditure, to the heads of the hospitals. Because the heads of the hospitals, and this happens in Nakuru, I went to a level 5 hospital there, the head of the hospital is able to, is allowed to spend, because he has the FIF, the money that's ring fenced, and they're able to deploy that financing. Whereas in other places, they have to go do approval at the county, and then now it takes some time for that to happen. I'll let you have the last word, and then we will close.
Wangari, to that point, actually, initially, we thought we would take all the money from the hospitals and give them back, the PFM way. But I want to agree with you. The FIF fund is the way to go for every county. The AIE works. We also used it at my county, and many counties use it, so that you give them the authority to incur expenditure, and with an approved fund, because every fund has to be approved anyway. With an approved fund, they are able to use the money at that level. Wangari, to the point that she has just raised, I'm just wondering how we ensure that anyone wanting to fund government actually get to see their strategy. Because if you look at my strategy and the priorities that we have, then you can identify a need through maybe the strategic papers that exist, or the fiscal, not fiscal, what do you call it?
The county fiscal.
The CIDFs. And, other documents that show what government intends to achieve. Because again, when you bring something that citizens do not have a need, it will not be used.
That's true.
And I have seen projects that have, been implemented with donors, and they are dormant, simply because it was either a project too big for the community, they don't know how to use it, and, there's a challenge. So there is need for donors to look at the need, even through the papers, at least address a need that has been identified.
Because remember, even what used to happen with CDF
Yes.
and LATIF is that they build a big hospital.
Yes.
But because many times, in some instances, they were not linked to government.
Yes.
Or maybe like the MP has built a big hospital, they have not linked to government. So they have a big building, but they have no doctors, they
Yes.
have no equipment, etc. So that is a big problem. So I want to close there. I think we've had some wonderful discussion around the question around how to rethink financing, especially for universal healthcare, and how we can expand the space, fiscal space for financing healthcare in general. To our listeners and to our viewers, we are going to put all the points that we've discussed here in a policy brief that will be accessible on our website, as our podcast will also be available on our website. And we look forward to engaging with you on more policy questions. If you want to come and join us at our table, if you have a topic that you'd particularly like us to discuss, please let us know. The contacts are on our website, and we hope that you will follow and join us again. Thank you very much.